You know, in Germany, we usually say in our TV session, you're always sitting in the first row, so if you want to. Okay, welcome everybody to our, oh, it's really hard to read. Welcome, no, I understand what you're saying. Welcome to our symposium, Applying Intersectional Lens on Dementia Care Research. But before we start with the content perspective, I got an information, since this is a hybrid session, as you already can see, the camera is behind us. All the people who are here virtually, they have a possibility to also ask questions. And I have a tablet here, so everyone who is virtually and has any kind of questions with regard to our sessions, our presentation, can do so. But what I understand is that the audience needs to download an app to participate in this Q&A session. And then this app is also for voting the in-person poster, which is in a room Constanta, and can be accessed by the QR code, and then you can vote. And the voting is closing on Wednesday at 4 p.m. And you need to select at least 5 posters. Okay, so this is all. And as you already can see in the first slide, we were originally 4 people presenting, but we lost 1 person due to sickness. So it's only going to be 3, but we still try to have enough time for discussion. So I will start with my presentation, and then afterwards it's going to be Huerrem Tecan-Guentekin. I see the Z never makes it in my presentation. So it's like I will talk about the scoping review, and then we have 2 studies, Huerrem and Carolien Smits, on empirical studies, and we thought it might be a good combination based on the topic of intersectional analysis. So my topic specifically is on intersectionality and dementia care research. We are conducting, as a task force of the InterDem meeting group, which is called Cultural Aspects, a scoping review on the topic of intersectionality. And I'm going to explain a little bit more what we mean by this. So first of all, I want to remind you, this is also something you can find on the website. We have 2 aims as the Intercultural Aspect Task Force of InterDem. First was primarily to identify gaps in dementia care research, and specifically after some kind of discussion within the InterDem members, the intersectional, focusing with an intersectional lens, and I'm going to explain a little bit what we mean by that. And then, of course, based on what we identify in the research, to identify some kind of ideas what else we could do when we talk about future research. Because, I mean, from my understanding, it's like a new methodological approach and a new content approach to do research in a different kind of way. And I guess we have 2 lovely presentations who will give you also an insight in what that means to do it in qualitative research. I just came from my holiday, so I already said if I'm falling asleep, that is due to my US time. But I went there to an exhibit from transgender people. And I brought one description of one person who was actually a trans woman to trans men, and he used the term of intersectionality. So I'm just going to point out, and I think this example explains what the difficulty is when we are using the intersectional lens. So this person said, when I think about the fact that my family has been a refugee for 4 generations, the way I choose to understand the narrative, even though there's a lot of pain, there's a yearning to be free, living at all cost. That's sort of how this transnational refugee identity overlaps with the trans experience for me. Having so many intersectional identities, being queer, trans, Palestinian, American, person who was raised in the South, Muslim, Buddhist practicing, married to a Jewish woman, all things our intersectional identity perspective. And that is exactly pointing out to the complexity of what we're looking at. I'm just not a woman only. I'm just not a dementia researcher only. I'm also many other things. And that is what we have to address when we talk about intersectionality. And the second part is already referring to, let's say, outsider, others define me, insider, how I experience myself, because it is saying the absolute pressure I felt with all these intersectional identities. I felt the narrative around me telling me I can't exist. Because others were saying, hold on a second, that can't be. You can't be as a Palestinian married to a Jewish woman. You can't be queer when you're a trans man. So, and I think this already refers to how society predefines how my identity might be defined. And then the experience I have as that person is, now hold on a second, what I'm doing it. I mean, I feel I exist, but everyone is telling me that can't be. So how can I get to the point that I can say I exist? And this is really then that we have to address intersectionality in a different kind of way. So I think this provides you with some kind of glimpse of what we're trying to do when we talk about intersectionality. So the task force at the moment is in preparation of the scoping review. So we have already published a paper on intersectionality linked to the migration, people with migration background, and we identified lots of gaps because the gap is primarily in reference to what I just tried to say, that we have boxes where we put people in, and then we talk about the boxes, but we're not talking about the relationship of these boxes within and the construction of these boxes and what that may mean. So we are preparing the study protocol, and at the moment we are doing the scoping review. So the focus of the preliminary results I'm going to talk about is more like, how do we approach this? As you already can see, that it's not a typical read the text, an article, and then have new boxes, and then in the end you can say, well, this is what we're going to do. So what we had to consider when we were talking about what does that mean to do qualitative intersectional analysis in a literature review, first of all, we have to think about how are social categories used or defined. So it's up to the group to define what kind of social categories are we looking at. So of course the typical is usually biological sex or the social construction of gender. Usually we see lots of gender, but it's actually biological sex. So that's already a starting point where we have to be sensitive that if I'm seeing an article that is referring to gender, that they don't mean the social construct of gender, but they're actually talking about men and women. So, and if I already see that there might be not other definition of what we mean when we use the term of gender or sex, then I have to look into the meaning of these constructs that are used in research. The second one is which social arena. So in our case, of course, that is probably, not probably, but that is dementia care research. But it's also dementia care, and it's also in different kind of care settings. It could be about family caregivers, but it could also be about distancing of care. So everything that we need to define based on. And then the next one is a little bit, we were talking about it this morning with my colleague Francisca, who was also here, what historical processes or outcomes? I mean, she comes from Berlin, I lived in Berlin, maybe for most of part of my life, and it is always a question of how often do I think about how I present myself when people are asking me, where do you come from? So as long as the wall was there, when others asked me, where do you come from? I said Berlin. And then the others were saying east or west. So, and then of course that was a way to understanding what kind of knowledge do you bring to the table when I talk to you. And I think usually we don't talk about it. We just assume that when I say Berlin, you have an idea, oh, you live in a 4 million city, and of course it's different than rural. So I think we assume what that means when I live in Berlin. In Germany, that might be fine, but if I talk to internationals, they may have some kind of whatever ideas about what that means. And usually we don't talk about that. So for example, my parents said when the lockdown came, they are all the Second World War kids, they said, oh, this feels like we had the Second World because we were going in a bunker. We didn't have anything to take care with us. And they said, well, you know, I am familiar with that one. And I said, hold on a second, I've never experienced this kind of thing. So I think what it addresses is that we have to consider the historical context where terminology is coming from. So the recent paper, which you're probably all familiar with, is a good example how we could look at it from an intersectional analysis. So for example, they are saying people with dementia do not form a homogeneous group. So now, of course, I can say, which group are we talking about? The people with dementia? Or are we talking about people with dementia living in a different country? Or are we talking about women with dementia? Or are we talking about men with dementia? Are we talking about people with migration background? Are we talking about intergeneration kind of group? So the first thing when we talk about groups is, and I'm pretty sure you're familiar with it, that very often we see, oh yeah, I analyzed women with dementia and the outcome is ABC. But we have to criticize how that group is defined. And I think this is what intersectionality can provide. Then there are also, and it still stays with that homogeneous kind of understanding, there are also numerous subgroups of people with dementia whose experiences and needs should be viewed as results of a dynamic intersection between different shared characteristics and collective experiences. So it could be that we are saying I have a subgroup, women with dementia, but the differences lies within the experience. And then we have to address what constitute that kind of experiences, and we have to address what constitute the overlaps. And how can I understand the overlaps or the difference, and what would that mean if I interpret the results of what people are telling me? And then the other one that is also a term that has come up recently, superdiversity. So the example from the trans person I was referring to in the beginning, that is what we would call, well, is called very often superdiversity. And then of minority ethnic population, that would also be true for the trans person, drawing attention to rising diversity within groups. So as you may recall, the trans person was referring to, I'm a refugee, I'm coming from Palestine, so maybe not each Palestinian who lives in the fourth generation in the US has the same experience, and that would be something we have to address within an intersectional approach. And what I want to point out here is really the inside-outside perspective, because we have to handle the construction of defining terms, let's say groups, or social construct like culture, or social understanding of religion, and then we have to see what does that mean with me on a personal level, and at the same time I have the self-identification. So maybe, as you recall, maybe with the trans person, there was a reference to what others were defining when talking about him, and what he himself said, what he thinks he is. And I think this is really what we have to address in intersectionality. So what does that mean for our review? So we came up with two key research questions. How is diversity of people living with dementia reflected in dementia care research? And then the second one is, how are intersectionality and intersectional analysis applied in dementia care research? As you can see, of course, we assume that there will be lots of gaps based on what we saw. So the inclusion criteria, as you can see, I'm not going to read through everything, but what we try to do, as you already can see, we have the key languages in English, and then based on the international group and the native language of the international group, we have also different languages allowed. We did not restrict the year because, I mean, we can already see there is an increase over the course of the last couple of years. And then so far there's one book which we were able to include which addresses directly dementia and intersectionality, and out of the 500 articles we were able to identify 51 after TIAP screening. And then you can also see the data extraction plan, and I'm going to talk about a little bit how we are going to analyze our data. So usually when we do qualitative analytical approaches, we have this a more additional kind of perspective. We say, well, you know, I combine age with refugee, or I combine age with women, or I combine age with whatever. And then, but we never look at how age influences refugee identity, or the refugee identity has something to do with age. So what we are trying to do is more like that we have to be careful when we read this article of not, you know, going into that trap of additive analysis. We have to focus on the relation, like I was explaining. How do these topics that were addressed interrelate, and how do they influence each other? And then it's the influence that we are looking at, and that could be an overlapping or it could be a difference. And then also the focus on social constructivism, so that is more like what kind of terms I use. For example, I was using the sex-gender kind of discussion, so it's more like a question of are they actually talking about gender, or are they talking about sex? What I have already seen is that when we have LGBT or trans studies, then the use of the terminology of sex, binary, non-binary sex, and gender is totally different than if I'm not talking about this particular group. So I think that already is a reference that we are using the terms gender and sex in a different kind of way, and that is what we can identify. And then the next level is also that we are looking at, is this more on a conceptual level? Because then we're talking about what it means, what defines us. Maybe some of you have read in the 80s Judith Butler, because she was saying, if I see a person, I always want to know if that is a woman or a man. Unconsciously, because I already have been trained, maybe not in a daily basis, that my mom was pointing out, this is a man, this is a woman, this is a man, this is a woman, but unconsciously we try to identify who is that person representing. And it's hard to overcome, but that is exactly what we have to look at, like I explained it with sex and gender. That would be on the right-hand side, anti-categorical. It's more like a discourse analysis. How is the discourse applied to on the subject level? And then we have the intra and inter-categorial, and one is more on the subject level. How do I self-position myself, as we have seen in the trans example, and the other one is more like between different kind of categories that might be of relevance for the research, and then see how they influence each other in a different kind of way. And then, of course, we have to use a model. We are using the model of McCall, who described these categorical analysis as a key part for the intersectional analysis. And I brought you some kind of example. So one is to deconstruct, to have a better understanding of, for example, the binary or non-binary sex markers. The intra-categorial could be, as you recall from the Alzheimer Europe paper, they were saying there are also subgroups, but then the question is, within the subgroups, is there overlapping heterogeneity? And then to identify how this heterogeneity or the homogeneity can be defined, because that's the relation. And then the last one is more like, how do I self-define myself and how I might be defined from the outside? But you already can see we're talking on different kind of levels. So when we look at the literature, we have to keep in mind that we have to identify what is the key topic when we analyze the literature. So we are doing a thematic analysis, which you're probably familiar with. And then, as you already can see on the right-hand side, You see the key result will be the qualitative analysis based on McCall's model, but we also will be able to sort the papers. Is it more conceptual? Is it more methodological? Or is it an empirical study, as the two presenters that are coming after me? And then by doing so, we have to be aware of not stepping in the typical qualitative kind of research we are usually doing by categorizing and not thinking about how the categories are linked to each other. And that's for me for the moment, and I hope next year we will be able to present the results of the scoping review. Thank you very much. I think we can move forward directly. Let me see if there's the audio quality is low, hard to understand online. Sound much improved. Thank you. Okay, Huerrem.
Yes. So hello, everybody. We conducted a secondary data analysis with my colleague İlknur Özer Erdoğdu. She cannot be here today, but she sends a lot of greetings to you, and I will start my presentation about racial discrimination of Turkish dementia caregivers in Germany. Maybe a few sentences about why we put the lens after the primary data analysis to this intersectional thing. The first step we made during conducting this research was only with the focus on migration. We only wanted to look how the self-management competencies of Turkish family caregivers of people with dementia are, and the first thing we thought was that the fact that the people were migrated is the most affecting aspect. And after we made this analysis, we found out that the sample is so heterogeneous that it is very hard to say Turkish family caregivers are like this or they are like that, and it felt not good to talk in this way about these people. We conducted the study, we closed it up, but this feeling of not feeling good stayed. And it stayed so long that we took this data again with the discourse of racism and intersectionality rise in the last years in public health and in nursing studies. It is new, it's a new discourse. And then we thought about this results and we thought we have to put this data again on the table and we have to look again on it because we thought that we will see other things now. And it is really so. We haven't finished this analysis, but today I brought one case study with me. We thought that it is better to look on one case to understand which effects this intersectional things can have. So now I will start. Yes, I've got the time in mind.
Yeah, you have to do this.
Okay. Who is actually affected by racism in Germany? We have got new data about this from the Dementia Institute. Racism is a structural problem affecting society as a whole, which is primarily related to socially inherited power structures. 22 of the respondents are directly affected by racism. 58% of potentially racialized persons state that they have already experienced racism. And this study asked for indirectly affected people also. And there are 49% who know the racialized person, and 45% have already observed a racist incident. And so a great part of the population, with 75%, is directly or indirectly affected by racism. Almost every second person interviewed is aware that it is not only an individual problem, but also an institutional or structural one. We have another survey about racism in the field of healthcare from the Afro census. And in the field of healthcare, for example, Black, trans, inter, and non-binary people experience discrimination particularly frequently. These are the first surveys in Germany which shows us this intersectional effects. And compared to cis people, they state here most frequently that they experience discrimination with 81%. Among cis people, it is so that about 50% of men and 67% of women report having been discriminated in the field of healthcare. There is a huge gap between those groups. And another thing which shocked me personally is that over 90% of respondents say that they are not believed when they report experiencing racism. They hear something like, maybe the doctor hasn't got a good day, or everyone is sometimes not so good, and so, and they are not believed in the things they are experiencing, 90%. So we can see here that there are intersectional experiences of discrimination are in reality fact. A short definition of intersectionality. In the critical diversity discourse, intersectionality is a central construct. There are different definitions about this. This originates from the women's movement of the 1970s in the US and refers to the multiple discrimination of Black women in the professional environment. And one possible definition by Weigenbach is intersectionality is understood to mean that social categories such as gender, ethnicity, nation, or class cannot be conceptualized in isolation from one another, but must be analyzed in their interweavings or crossings, intersections. And it's very important to understand that these overlapping characteristics cause inequality in a very different way than single characteristics and are influenced by societal power structures. The primary study was about strengthening self-management competencies of family caregivers of Turkish people with dementia. We conducted 10 problem-centered interviews with family caregivers and 11 expert interviews. I don't want to talk so much about the results of this primary study because of the time. We conducted the qualitative content analysis in this primary study and then a secondary data analysis with the intersectional lens of Riegel. And that's an instrument of analysis and reflection about identifiable social categories and their interactions, as well as the production and reproduction of social difference. So very short, the acceptance of the disease in the Turkish community is low. There is a taboo about dementia. The care situation is so that there is, in general, family care, less additional external help, but in some families they take some help with wound treatment and so. There are language barriers, especially in the first generation, and the dementia, the people with dementia, they forget the second language, German, in Germany very early, and that brings the people to the isolation. They are ashamed about it because they realize it. Mental burden from the family caregivers are strongly there, and they seek help very late. The people are feeling, all of them feeling guilt. Even the people doing the care at home and the other people giving the person with dementia to a nursing home, everyone is feeling guilt because they think it is not enough what they are doing and they should do more, they should be more there and so. And helplessness and role conflicts are problems too. So I will skip this. You can read, if you want, in these publications the results of the study. This first one is very interesting because it's about ethical and methodological challenge with while doing research with this group. And I skip to the intersectional lens. So I'm sorry. Here you can see the publications. The intersectional lens of Riegel brings us to ask the data a few questions. And you can see here the questions. The first one is, which social categories and dominance relations become relevant and how? How do these interact? Second one is, how are these social differences and relations of inequality, situational, habitual, or discursive, produced and reproduced through practices? The third one is, what are the functions and consequences for the subjects involved and for the social order of the system? And this last one is, what possibilities are there to break through the reproduction of inequality, structuring difference formation and dominance orders? So this intersectional lens of Riegel fits very good for a secondary data analysis because it is additional. And you can combine this with other reconstructive qualitative methods. It is very open to this mixed methods approach. And today I will show you how we work with it. The study I want to present, the case study, is about a couple who migrates from Turkey to Germany in the 1980s. The man is diagnosed with Alzheimer's dementia at the age of 52. The woman was 48 in this moment. The diagnosis is a huge shock for the family with 3 teenage children, and the husband gives up his job. The wife works part-time and cares for the husband. The husband is not accepted for daycare because he cannot actively participate. And after several epileptic attacks, he is treated with medication in the hospital, and the professionals at the hospital recommend that he be admitted to a nursing home. She took the man at home again and made the care at home for a time, and then after a fall, the hospital refuses to admit him, stating that the wife preferred to care for at home. They take him in unwillingly. After increasing pressure from the hospital to admit him to a nursing home, the woman agrees, even though she wants to continue caring for him herself. And shortly before admission to the nursing home, she tells the hospital that she cannot do so and will continue to care for him at home. And now we see a citation of the interview. The wife said outside in the corridor, the doctor says, "We are here in Germany. You cannot decide how you want. We were shocked. Do you know how the man yelled at us? I cannot describe it to you. He says, you will take this patient with you tomorrow. It was Monday. On Thursday, the things, nursing aids and the bed, were supposed to come. In this hospital, all we were told was, he's going to die, he's going to die. In the hallway, they said to my children, your father is going to die. We wanted a percutaneous endoscopic gastronomy. They said he's going to die and they will not do anything for him. We should go somewhere else. We were not helped there at all." The man was discharged not a day after. He was discharged on the same day in this moment, although the nursing bed was not yet at home and the discharge was scheduled for 3 days later. The family improvises a bed out of mattresses from which he cannot fall. 3 days later, he becomes calmer. The family uses outpatient palliative care, and 2 weeks later, he passes away. And she told the situation to me. And if we think about the questions of Riegel, the consequences for the subjects involved was for her in this moment, the wife is still intensely affected by the experience for a very long time. We took the interview a few months later. Right up to the end of the interview, she repeatedly refers to the experience. She told, for example, later, they knew I was a foreigner. They couldn't have done that to a German. They couldn't yell at the German in the middle of the corridor like that. And my daughter can speak German very well, but she couldn't answer anything because we didn't expect something like that. And she says, German relatives are spoken to inside in the doctor's room. With the Turks, they talk outside shouting. They did that, they really did that. Afterwards, a friend who was with us complained about it. I don't know what happened to it. He went away yelling at us. He doesn't even stop to talk to us standing up. We were there with my daughter and the friend was there. He came out screaming and went on screaming. It's just dogs here. The dogs are supposed to listen. They could not have sent a German away in that condition. He was very sick. The woman, she took this experience with her, the loss of the man and the experience of being getting treated like this. And if we ask now the questions of Riegel, which social categories and dominance relations become relevant and how, we have got some social categories like being a woman, mother of 3 teenagers, she's a migrant, she have low German language skills and a low educational level. She have got little supportive structures in the environment and financially big responsibility. If we look on the dominance structures, then we see the professional dominance between doctor and the family caregiver. There is an asymmetry. The doctor tells her how she has to act in his country, Germany. And that's the part where this exclusion is very, you can see this exclusion very good. The territorial dominance, the conversation takes place in the clinic, but in the corridor, which is perceived as a devaluation. And the doctor has chosen this place for talking to this family. It was the corridor, it wasn't a room. The financial dominance is that she wants to care for him herself, but must continue to work due to precarious financial situation. If we look how these categories and dominances interact with each other, then we have got this interpersonal level, being helplessness in the face of her husband's situation with a simultaneous great desire to care for him herself. She has got language barriers and a doctor who is culturalizing her decision. The daughter, who has a very good knowledge of German, is also silenced by the doctor's action. She is a single mother, is financially dependent on job, and she has got feelings of not belonging and unequal discriminating treatment. On the structural and the institutional level, we can see that taking advantage of the professional and territorial power in the clinic by the doctor, the woman is at the doctor's mercy because her husband needs help. She cannot go away. She has to go to this clinic or to this doctor. This happening in a small village. It's not Berlin, so that you can choose between 49 clinics or so. And lack of willingness to provide support that meets her needs. If we look on the socially or legally level, we see that she would like to stop working. She told it a few times, but the financial support from the nursing care insurance is not enough to make this with 3 teenage kids and a household. If we look how these social differences and relations of inequality produced and reproduced through practices, then we see there is a degrading communication by the doctor. He is shouting at the person's humiliation of relatives in public when passing by, not taking adequate space and time for the existential conversation. The wishes of the relatives are paternalistically ignored. The doctor determines what is right for them, and the doctor punishes them with the immediate dismissal of the person with dementia on the same day because they have not followed the doctor. Here we see that he practices his power. So I come to my conclusion. The powerlessness that family caregivers are experiencing is multiplied by the practiced power and structural discrimination. If we put this case to a family without a migration background, for example, things like this can happen. But it can be that the person have got other diversity characteristics and then can help herself in a different way. But if there are a few of the diversity characteristics crossing with each other, then it is not possible. She has no possibility to tell her experience to an official place. She lives with the traumatic experience, and the doctor don't have consequences. The intersectional aspects and the effects of power asymmetries only become visible through the consistent analysis through the intersectional lens. And in public health and nursing science, there's hardly any scientific discourse about racism in nursing and healthcare in the German-speaking countries so far. It's a very new discourse, I told. So last one, and I'm fast. So we need the intersectional perspective, even on the research level and on the care level. And this is only possible through reliable statistics and monitoring of experiences of racism in nursing care and other fields as well. Establishment of complaints departments for experiences of racism in care. And professionals who act in a racist manner must face consequences. They don't face consequences in the moment. We need a different catalog of criteria for quality management, which includes racism, critical and sensitive nursing, and medical care. So, and with this, I thank you very much for your attention.
That was perfect on time. And now I introduce Carolien Smits to the presentation. We will save the questions for the end of the session.
Hi, everybody. My presentation actually links really nicely with Huerrem's talk, because I'm going to be talking about the study on family carers, migrant family carers too, and how you can apply sort of an intersectional lens on that. So, sharing of care in family carers with a migration background, and I'll be talking about the application of an intersectionality lens in both research and the development of communication tools. So that's the sort of the special thing about this project. That's both academic research and based on the findings, we developed communication tools in co-creation with the end users. And just now, I'm going to show how intersectionality was applied in both work packages, so to speak. So, sharing of family care is a very urgent matter in dementia care, and that applies to all family carers, because it's such a difficult and prolonged task. It's very tiring and overburdening. But research has also shown that it's even more burdening in many migrant groups, many migrant caregivers. So that's one side of the coin. The other side is that care professionals like nurses and general practitioners find it very difficult to address this when they talk to patients and family carers. They find they feel that they may be trespassing, such as sort of the sensitive issues that they suspect behind one particular family members. They don't know what the other family members may think. And they may also assume that, in migrants, they take care of themselves. They don't want family care. They don't want professional care. That's a sort of an implicit assumption that is not correct, but it just illustrates how difficult it is for care professionals to address this. So this project, Taking Care of Caregivers, addresses this. It aims to study the underlying mechanisms using an intersectionality lens, and it aims to co-design tools that may be used to support the discussion of professionals and carers on sharing care. So first of all, the products that were already have been produced over the past 4 years. So first of all, the PhD papers by Minal Ahmad on dementia care in families with a migration background, dealing with gendered and cultural obstacles to shared care. I'll tell you a bit more about that later on. And then in the second half of the presentation, I'll focus most of the time on the tools that we developed, being online communication training for care professionals, addressing sharing of care in migrant family carers. We developed vignettes for your professionals to be used. We designed a web page with lots of videos of family carers addressing this and telling about their personal experiences. And we designed a podcast series for professionals on this topic. So intersectionality. Have you all, now you've done 2 presentations, have you all have some sort of idea what it is? Because just before we started, I spoke to somebody and she was saying, oh, I'm not sure if you're gonna get a lot of audience because we don't know what this really is. So I hope, and it is in the sense very abstract notion. So if you don't get it, don't blame yourself. Just ask us afterwards, because it took me some time too. So intersectionality, and Martina and Huerrem already described it in different ways, but it's the notion that all individuals are shaped by the intersection, sort of the crossroads of different social categories. So it's a lot about social categories, and they're not rigid, they are dynamic. And the usual ones, but they can be, expanded, are ethnicity, gender, class, age, and relations. So they are sort of the usual suspects. It can also be defined as a lens through which we can identify how multiple social categories intersect at the level of the individual experience. So it's all about the experience. It's not necessarily about the formality, the structure, but it's how these categories are actually experienced within a broader system of power. And that's Huerrem gave a very nice illustration of that power system. So, but most of all, it seeks to clarify relations of inequality and privilege. So, focusing on Minal's research first. So, the 1 to 4 are the sort of the chapters, the papers that she published. But her research question really focused on the perception and the experiences of carers of persons with a migration background and dementia on care sharing within the families, but also with formal care. And she had a very much qualitative methodology, interviewing 31 family carers, 10 practitioners, and she used semi-structured interviews, photo voice interviews, life story interviews combined with shadowing observations and focus group discussions. So in the end, which social categories are expressed by our participants, and how do these social categories relate to our participants' experiences of care sharing? And Minal actually concluded that it's the intersections of migration, history, and social class influence the attainment of necessary skills to organize and share care tasks, as well as perceptions of good care. And the second one is that one's position within the family, the presence or absence of supportive social networks, religion, gendered care norms, and relationship to the care recipient are relevant to experiences of care sharing. I'll give you 2 examples. One I remember was a Chinese daughter of her father with dementia, and you would expect, sort of from the migration simplistic literature, that she would feel very compelled to go to tremendous length to take care of her father herself. But this was not the case, and it had to do with her family history and her personal history and education. So in this case, this Chinese family of parents and one daughter came from Taiwan, and they moved to, at some point, they were highly educated and highly skilled professionals. They moved to France at some point, where our respondent was educated, and from then on to the Netherlands. And this meant that our respondent, this daughter, didn't feel, she was highly educated, so she didn't feel very pressed by the norms and the cultures that you may expect from the Chinese, like respect your parents and family above all. So this meant that she was not, the family was also not part of a sort of a Chinese community in the Netherlands. So that means that she was not sensitive to any community pressure to take on any or further sort of pressurized to take care of her father herself. So these are two experiences relating to social categories that were important for this case of how she, in the end, organized and shared the family care. What's more, being highly educated meant that she could reflect on what is, in the end, good care. And and she decided that in this particular situation, in this particular crossroads of the context and the historical context, it is best as long as her father had good quality care. And it didn't really matter if it was provided by her herself or by a care professional. There's another example that may be sort of the opposite. And and this example was, of course, the daughter. And the example that I'll present just now is a partner, a wife of a man with dementia, with a Turkish migration background. And this already elderly woman, she had been taking care of her husband for quite some time, and she was really getting overburdened. But in this case, she couldn't really discuss this sharing of care, although that she was ambiguous about it because she felt that she was going down, so to speak. So she did send out some signals, but in the end, she felt so sort of tied to the norms and the values in her family that it should be the wife who should take care of the partner, and certainly with her Turkish ethnic background. And she, of course, she was embedded in a strong Turkish community. So this is sort of examples how migration and gender, of course there's a lot to do with gender, are not decisive categories when it comes to actual experiences and actually sharing of care. So implication of this research part is, rather than overemphasizing ethnicity and culture, practice and policy should take into account that intersections of various social categories affect care sharing and the type of support that is or is not organized. So now to the second work package, dealing with tool development on the basis of Minal's research findings. What we did with, so we had sort of three end users for the tools. We had tools for the care and social professionals, we had tools for the family carers, and we had tools for the education of care professionals, for the sort of the Universities of Applied Sciences. And they all, we used three separate co-creation teams to develop these tools. And on the whole, they had the same sort of stepwise approach of meetings to discuss to building trust and to find out what's important for them in this field and to discuss the requirements that any communication tool should come up with. And then further on, of course, sort of are these requirements met in the sort of the professional tools that were created in between these meetings. So that was a really enjoyable and dynamic process. But looking at it, just as a further elaboration, we used convenience sampling, quasi-purposeful sampling, focusing particularly on sex and gender, ethnicity, and relationship of the caregiver to the person with dementia and to education. So we try to really cover that in our teams, in our co-creation teams, and we had, of course, these group meetings and iterative tryouts by the team members of the co-creation teams. So now my reflection on the use of the intersectional lens in tool development, and I must say this is also some sort of looking post hoc, looking back and trying to find out how did we actually do this from this perspective? Did we actually pay justice to the intersectionality lens when we were co-creating this? So in the end, if this is for me this first time that I talk about this, so if you have any suggestions afterwards, I'd be very happy because I think this is really about teasing out what we did and what we should have been doing. So one of the important things about when you apply this intersectional lens is that you have to decide on which social categories that you're going to focus, because that's going to decide a lot of what you're going to find. Of course, these were sort of chosen almost beforehand. It was partly based on Minal's research, and it was partly based on the research literature in general. And thanks. And some came up during the co-creation process. For instance, the position in the family, the migration history, and also some may have been missed. I don't dare to bet my head on that. So, what are challenges to implementing an intersectionality lens when you co-create tools for any particular user group? In this combination with research in the first place, and so the research took 4 years, and we started tool development in the second 2 years, so we had to wait in a sense for Minal's findings. So you always have this backlog of research findings and doing the tool development, because Minal was still coming up with findings during our tool development process. So that was a disadvantage. What we did nicely, I think, that we had partly overlapping actors in the research part and the co-creation part. So one of our co-designers was actually participating in the research part as a supervisor. But yet that may have done that even better, I think. And of course, there's a disadvantage of what I call the project push. A project has its own dynamics. A project, by definition, has to be completed at a certain point, and it has to deliver at a certain point in time. And that means that you don't always have the space, the time and space to reflect on the sampling and the recruitment, and also things like positionality of the researcher. The good thing about our process was also that the implicit expertise of the participants was really good, because they were partly people who were very grounded into the practice of older migrant lives. So when we were actually doing it, we actually came up with these social categories almost implicitly. So that's in the end you come up with almost the same social categories and mechanisms. So that's the interesting thing. And in conclusions and some recommendations, so the use of intersectional lens in both research and in product design, tool design is feasible, it is productive, but it can remain implicit in tool development unless you explicitly reflect on it. I think it can be even more productive by more and earlier interaction between a research team and the co-creation team, and it means more overlap in planning and team members. And in the end, it's important that that you need to create space for structured and also spontaneous reflection and team discussion on intersectionality and positionality. So that was my presentation. Hope to hear from you. Thank you. And the papers, Amal's papers.
Yeah, thank you very much. I just want to remind the people who are online that you can post your questions, but you need to download a specific code in case you missed that what I was saying in the beginning. Okay, great. Also very good in timing. So I think we have lots of time, I mean not lots of time, but some time. Emergency room, Diane, you should have tell us. Oh, sorry, I pushed the button and I didn't know that. It's so loud. But I think I'm awake now as well. Anyway, you are awake, we are awake. So we have time for questions. And please,
Thank you very much.
I think, I don't know.
I've got a very loud voice.
Here's the mic.
Thanks. I do have a very loud voice. Very, very interesting. I just wanted, with my researcher hat on, and from a practical point of view, you've got these categories, the intersectionality of them, and the individual experience of people. Yeah. So when you're actually recruiting people, I mean, I'm just interested because I don't know, you'd have to go back and interview people several times to be able to create that story that they have. So as far as you'd have to be iterative, that you would be analysing as you went. So, because everybody's experience is individual, and as you said, Carolyn, two experiences of two people from another, ethnic background about their responsibility of caring. So I just wanted the sort of practical side of things about how you have a bit of a sample, because, I mean, often with qualitative research you use theoretical saturation as some way of saying, I've probably reached. So I just wondered a bit about the practicality of doing that.
Well, maybe you start first, no? Can you pass the microphone?
I can answer. It was fast for me, my English.
The recruitment. The challenges with recruitment within the group, for that population you were talking about.
Okay. Normally,
should I turn this off? Maybe this one as well.
for example, in the study I talked about, it was, in the beginning, it was a linear process. And after the first analysis, we decided to make an iterative process of it. And then in a few of the cases, we took a few interviews with the persons. We stayed in contact with all of them. A few wanted more contact, another not so much, and we was very sensitive with it. Because of ethical aspects, we don't understand research as data collecting. It is relationship. We go in a relationship. In this few hours we are in the family. We wanted to conduct, for example, 45 minutes or 60 minutes interviews, but in reality, we stay there for a half day or for a day. And my students, my topic is qualitative research for public health students, and if I tell them how they have to make their research in the field, then I say to them, please plan only one interview on this day, don't go work before, don't go work after it, don't make plans for this day, because you need this time to stay there if the feeling and this relationship needs this. Okay, maybe we can discuss about it, if it is enough space between the researcher and the research person, but I want to come back to your question. I think the possibility to go again and again in a family should be reflected very good in the team, because the people talk about it, they cry, they are affected, and we try not to affect them very negatively, and that's why myself, for example, they get my number and I say to them, please call me if you feel not so good afterwards, and we will look together for a psychologist also. Maybe I cannot help the person, but I can help the person to find another place for help. And some families, we feel that it wouldn't good to go again in this environment because they are very negatively affected. And I must say, if we are applying for studies, for projects, you said it, there is time stress, and you have to make the plan of the study so that you get this funding. For the first thing, you get this funding. And in general, there are some 9 months or 12 months for this thing, but it's never enough. The time is never enough. But I think it's a political problem that it is very pushed for a small place. So.
But then I'm not sure if your question on sort of when do you reach saturation is answered. And I find that a difficult, I'm not sure if that sort of fits in the same paradigm as when we talk about this. What do you think, Martina?
So for my understanding, I mean, this is a very tricky question, you know, because I mean, on one side we're saying we have to be embedded in the community to really even be approachable. And then, for my understanding, it's also not to assume that we have to speak the language, but that it might be helpful. But, I mean, it's not like that I'm saying, well, you know, I want to do in the Turkish community and I have to speak Turkish. Maybe that person says, well, you know, I'm first generation, so I want to speak in German. So I think we have to reflect on a lot of assumptions we have. And then the second part is, I want to mention is, the embeddedness of the language in my daily life. So I think, and that was one question I had for both of you, since you did translate, at least you did translate, we know there is a dominance in the language. So we talk in English when we do research. We may talk in German or in Turkish or in Netherlands when we are in daily life. And then the question is really, for example, both of you were pointing out to what is your understanding of dementia. It might be totally different. It might be already assimilated based on how long I lived in the country that I took over whatever kind of definition. And I think the language for me is a critical part in a recruitment because it already depends on how I'm approaching that person and what kind of language I'm using. So the awareness we need here is that I really have to understand who's the community I want to approach and how embedded I'm in that community. And I think this is not only for migration, it is also the same for the community where I'm living in. And I am part of it. And what we already see is that maybe depending on the different kind of research we are doing in Germany, I see in general the person who are our study object, don't misunderstand me now, but our study object, they, well, you know, we are in distance to researchers. But if I'm a community-based researcher and I'm already seeing everyone in the church or in a supermarket or in a meeting center, then of course I'm a different person because I'm also a person, not just a researcher. And what I understood from the methodological perspective is that we really have to, you were talking about the relationships. Relationship means I, as a researcher, already have an interference of how the other person is reacting to me. And if I'm not making that as a point, even in the recruitment strategy, in the beginning of thinking about the recruitment strategy, then I already have a misstep because I might be doing the wrong things.
So, and in addition, it's good to reflect on that, because that's really the discussion on positionality as a researcher. Yeah.
Other questions from the audience? There's one in the back. Thank you very much. I see you're a runner.
Well, I don't know. Yeah, I actually had a follow-up on that issue of positionality, because I think most of your projects talk about intersectionality in terms of people with dementia and their family carers. But I was also wondering about intersectionality in professionals, and also, of course, in you as researchers. And particularly when you talk about positionality, when you have a junior PhD with a migranthood background in a team in which both the supervisors, or maybe all three, I don't know how many there were, have a Dutch background. And yeah, these are things that I faced myself, so I was really wondering about how you dealt with that.
Maybe I can say something? Okay. I think it's a very important topic, but most of the professionals, I will say professors, don't talk about it. They don't talk so much about the positionality of themselves, and I had 6 months in Germany. It's so all 3 years you have got 6 months. You can only make research and not giving lessons. And I decided to make my own research without funding because I was free for 6 months, and the project was about racism, critical self-reflection of professors of public health. And I had got 2 colleagues. I made it together, and only professors of public health with the interest of migration participated. And the results are very shocking. And we haven't published it, but it was worth to make research on it. And the self-positionality is very far from the reality, because the framing of themselves are very affected from power. And after a few years in this power position, you don't ask so much anymore. I'm only 5 years there. I'm from a working class. My parents are working migrants. And I cannot speak so good English because I never have got the chance to was abroad, and then it was too late because I've got children. So, and there are intersections and a lot more. So, and the only thing I can do is to talk with my students about this openly, about depressions, about other things, and make it very open. And then all of the students, they talk too about these things. And I've got so much students in PhD and master thesis with psychiatric problems because they know that I won't stigmatize them because of these things. And I've got migrants. There are not so much migrants studying public health. I don't know why, but sometimes they come to me because they know I try not to discriminate, because I talk with them about my discriminations. And I make it so clear. And the students come after lessons nearly every 2 weeks to me and say, I've got the feeling that you are discriminating me. And I say, oh, I'm so sorry, but I want to know why. And they are right. I talk every lesson about it, and I'm reproducing these things again and again. So.
Okay, I think that was a very good follow-up question, because I mean, I think if you go into intersectionality research, you will see that most are qualitative researchers, because then that is a familiar phenomena we have to address anyway. But I think what I learned by diving into the topic now for a couple of years is you really come to a different kind of understanding of how you have to involve yourself, because I mean the recruiting question from Deidre has something to do with a personal relation, and that means you have to be available as a person and not just as a researcher. But anyway, I think we could discuss a couple more hours, but our time is over. Thank you very much for joining our interesting session, and I hope we will see you next year. I think it's in Finland, and then we will talk about the scoping review and other results with regard to intersectionality. Have a nice conference and see you somewhere. Bye-bye.